talking about the VSD also. So Anze Djordjevic from Slovenia is going to talk to us about their experience with the VSD.
Thank you. Good morning, distinguished faculty, panelists, dear ladies and gentlemen. I come from Slovenia, from a relatively small cardiac surgery center compared to the US standards. Unfortunately, we don't have all the gadgets that were presented during these 3 days. We only have, aside from, of course, vasoactive drugs, we have the balloon pump and the ECMO. We don't have neither the durable mechanical circulatory support, nor the impella or the tandem heart. But even so, the aim of this presentation is to show that it is possible also in a small center like ours to make a good outcome for our patients in such a case. So our patient was a 68-year-old male patient, very similar to the previous case. He had history of shortness of breath, fatigue, and bilateral swollen lower extremities. And the symptoms have worsened over the course of the week before admission to the ER. He had no previous known diseases or medical therapy. He was on the vital parameters quite normal, but in the labs his troponin was high, he had high lactate, and he was in acute renal and liver failure. The guys at the ER made a POCUS and they found also a 2 centimeter large posterobasal VSD with a significant left-right shunt, also an inferior wall aneurysm and a massive tricuspid regurg. In the cath lab, they saw a proximal RCA occlusion, otherwise normal angio, and they decided, because it was already 5 to 7 days from the onset of symptoms, that they won't do anything with the RCA. They contacted the cardiac surgery and together we placed the balloon pump with the aim, as Dr. Gregoric already said, to wait for 7 to 14 days. Unfortunately, we weren't that lucky because the patient deteriorated, and on day 6 we had to go to surgery. This is the preoperative echo. I'm sorry, it doesn't work. During surgery, we made standard median stenotomy, aortic and double venous cannulation, went on bypass. We used antegrade and retrograde cold blood cardioplegia and performed a left ventriculotomy. We closed the VSD using the double patch technique. We closed the posterior aneurysm and do a repair of the tricuspid valve with the 32 ring and bicuspidalization. We've done it in under 3 hours of cross-clamp time and with sufficient on-pump urinary output. However, when the surgery was coming to an end, we wanted to, of course, wean from cardiopulmonary bypass, but although we had high inotropic and vasoactive support, the weaning was unsuccessful, and on the TE, the estimated ejection fraction was around 5%. We decided to put centrally placed VA ECMO and transfer the patient with an open chest to the ICU with both balloon pump and VA ECMO, and of course we were venting passively the left ventricle through the right superior pulmonary vein. Fortunately, the patient did quite well. His ejection fraction increased, no significant bleeding was observed, and so on postoperative day 1, we decided to go back to the OR to remove the left ventricular vent and to put in a peripheral VA ECMO through the groin using a 19 French arterial and 23 venous cannulas, so we were able to close the chest. Steadily in the days to come, the patient did quite better, and on postoperative day 4, the ejection fraction came to, I'm sorry, that was me, came to about 30%, so we decided to removed the VA ECMO after 86 hours. This is the postoperative TTA, where we can see the exclusion of the VSD. However, apart from our good wishes and everything, on postoperative day 4, the course of the patient was not so good afterwards. So after 12 days from initial surgery, the patient was transferred to our ward. Of course, the slow recovery was anticipated. He also presented with multiple pleural effusions, but then on postoperative day 40, staph aureus mediastinitis occurred, and we had to go back to the OR, remove all the osteosynthetic material, and put in a negative pressure wound therapy system, which was changed several times, and on postoperative day 63, we were able to remove the NPWT and close the chest. 2 days later, the patient was discharged home. So I would like at this point to thank you for your attention.
Thank you very much. Great case. Congratulations. I know that it's difficult without all the gadgets, but you did great. So any questions, any comments, please? Vikram?
You guys did, I think, a great job in walking the patient through this very, very hard journey with the chest being open, with having the mediastinitis complication. The lateral and the apex of the LV looks, down post-operatively after all the efforts. So even though the left coronary angiography system was quite good preoperatively, looks like the LV took a hit. The septum looked pretty good after the repair. So kudos, but it brings up the question of, even though the pump time was rather short, why did not the LV like the reduction in the afterload that much, and why did the lateral and the apex took a hit?
Well, it could be that there were some unidentified non-occlusive atherosclerotic disease also in the left system, but in the case of very severe VSD and shunting and massive tricuspid regurg, of course, our aim was focused in that direction.
And the duration of the VSD gives the impression that it was rather long, maybe, before, because he already came in, quite congested, and thus closure created this circumstance of increased filling pressures for the LV that it didn't like.
Yeah, I agree. Thank you.
Ajay, what were the tissues, because you said you went in there the 6th day, like we try to wait, like we discussed earlier. So how were the tissues?
Well, we were actually fortunate enough that even after 6 days, the tissues were strong enough to hold the sutures, and so we could perform the double patch technique.
Igor, let me make one comment, then we can have a question quick. I'm just very impressed. I think I learned a lot from this case, because it's important to realize you don't have the option for long-term support.
Yes.
But in this case, you transitioned patient very quickly so that you could come off by day 6. You came off via ECMO? No, day 4?
86 hours. So
okay.
Day 4.
The fact that you did so, and then the way you took care even quickly of trying to get to the open chest, you close it within a day. This patient would have been the same with an LVAD. He would have had an infection with a permanent LVAD, which teaches you a lot of, again, it teaches you a lot of the whole slew of other adverse events that we have to work on. We've got a lot of infection right now that we're dealing with, and it's just, again, it's a whole team effort. It's so many variables, but this patient would have had the same outcome with an LVAD potentially, and it's great. How's he doing now? I'm just curious.
Well, this is a case about 6 months ago, so as we know, he's okay.
Okay.
Yeah. I would just like to tell our opinion is that in a small center like ours, the philosophy changes. So we don't have the bailout like in other larger institutions, and so we have to improvise.
But you guys did great.
Terrific.
Yeah, congratulations. One more question.
Yeah, thanks. I agree. It was a terrific job. It's a high mortality operation, then infection on top of it, and you guys took that patient through. I have encountered this myself, in which VSD is early VSD, and the ventricle is kind of mush at the back, and it doesn't hold suture as well. and had a patient in which the ventricle tore as we were coming off pump, and obviously had a bad outcome. Then I started looking, and there are Japanese reports that have approached the VSD through the right ventricle. I started doing it, and that seems like it saves the LV, the morbidity. The RV becomes dysfunctional for a little bit, but then it perks up. Has that ever come to your practice? Have you ever thought about that? Or probably Dr. Grigor or Dr. Igor, because once you open the RV, the hole's right there in front of you. And you can either go from the diaphragmatic surface or the anterior RV surface.
Thank you for, great question. Well, in our center, we don't have experience with the right ventricular approach. We did a few patients through the right atrium, like in congenital cardiac surgery, but we wouldn't emphasize that because the results weren't that good. So.
Right, no, this is from the right ventricle approach,
yes.
either from the front or from the back.
Okay, thank you.
Great, but good job, congratulations.